you all for joining us this afternoon. We never take it for granted that you give up your lunch break, leave your offices, find parking, to drive here to see us. So thank you for being here. I'm Adriana Smith. I'm the Senior Director at UT Lavonner Pediatric Specialty Group at Lavonner. And on the panel today, I will introduce the folks here, and then we'll just go through some questions and leave some time for questions and answers from you all here. So I think we have two mics. My mic, this mic, okay. We'll make it work. So first here to my right is Representative Dwayne Thompson. He is from the Memphis area, and he represents Cordova and the Memphis area, and several of his constituents live there. We also have to his right, Dr. Andrew Watson. He's a TMA president, and he's a cardiologist at St. Francis Group. That's cardiology group. St. Francis Cardiology Associates. Somewhere in there, I can help you. Okay. And then to the end, I think no stranger to most of us, is Keith Norman. So amongst other things, he's the VP and Chief of Government Affairs and Community Relations Officer at Baptist Memorial Healthcare, and also a pastor at First Baptist Broad. So just welcome them, and we'll get started on answering some questions. So first off, I think that it's nice just to level set and talk about your views and your ideas and what you feel like are key issues in our area, maybe as far as legislature that needs to be changed, since that's the focus of our conversation today. But if you guys can just give just a few minutes on what you feel like are some of the key issues in our area that we're facing right now, in no particular order.
Okay, let's see, the key issues. Well, you know, in the Tennessee legislature, I guess the main issues, and that depends upon where you're at and what your philosophy is. It's a very, very conservative legislature. That gives you an idea. And we often find in the Memphis area that our thoughts and our needs and our views might not always be in conformity with the rest of the state, and that lends itself to a lot of the debates, some of the votes that come up, and even despite that, sometimes we actually come together and agree on some things too. So that's, in essence, that's what we do. I mean, I'm healthcare is a major issue in my district, and try to listen to everybody, listen to their concerns, and determine really what is the best way we should go as far as laws, healthcare laws, and legislation too. So that's essentially what my some of the challenges we have in our legislature.
I'll say it's coverage. I'll just shoot that one response, because coverage is the beginning of where you begin to solve all of the other issues. You can get to equity of care, you can get to eradicating the social determinants of health, you can dig into the other issues, but it starts with coverage. We have more people now, especially within the last 60 days, that will be without coverage across the state of Tennessee, simply because the rolls are being purged with TennCare, and all these issues are going forward. And I don't want Dwayne to jump out there and say that, because he's an elected official. So I'm going to say it. It's coverage, and it's coverage. Whether that's by way of expansion, whether that's by way of having grassroots workers who can assist, because I want you to think about something. If you're watching very closely the legislative body of the city council locally, they're seeking to expand broadband and high internet access in communities that have up to 72% non-coverage at all. But yet we send out letters from the state of Tennessee saying, go online to fill out this form to get your care. So we're creating more of a problem with coverage than solving. Once we get more people's lives covered, then we can get into how we really distribute healthcare in a more equitable capacity. So I would say the number one issue for us, and when it comes to healthcare, is coverage.
I would follow along with that as well. Excuse me. Coverage is really important in this state. Most people don't realize that the breadth of the state being 6 to 7 hours from east to west, they don't understand that in that same time period, you can leave here and be in New Orleans and cross at least 2 states there. So when you're talking about geography, it becomes a challenge for us to provide that coverage. The coverage for healthcare in Tennessee is kind of unique because we have basically 3 major metro areas with a 4th moderate-sized metro area. But we've got tremendous amounts of what I would call deserts in between that really present problems in terms of getting good health care into those areas. Sure, we'd all like to be next door to a major, major hospital or a major clinic area. It's not always that convenient. It's not cost effective to plant a major hospital or major clinic in an area, in a rural area, just because the utilization is so minor. So we've seen a lot of rural areas go uncovered or have their health care close up and leave town. The only good part, there's no good part about that, but one of the good solutions that's come out of this is telehealth, which is access to healthcare providers through internet. But again, that's very much broadband based as well, so we've got to have that infrastructure bleed into those areas to help us out with that. So we can make a determination, do we have a simple paper cut, or do we have somebody who's actually bleeding to death? And I would have, very much say in the same regard, coverage is very important because it is geographically based here.
Well, you all touched on quite a bit of what our questions here, so I'm going to jump to number 3. But what is being done to reduce the uninsured rate and improve coverage? What would you recommend as far as policy actions and actions by payers and providers? So maybe some things that you've seen that work, some things that we could be doing differently, some things that are being proposed maybe in the House of Representatives. What do you all see as a way to remedy coverage?
Well, the main thing is to expand Medicaid. I think that would be a relatively easy fix. It would be easy to do and easy to have it put into practice, to set up. The difficulty is that one, in most states, the governor of the state is the one to decide whether or not to expand Medicaid or not. In Tennessee, a law was passed by a former senator and former representative to say that the legislature, both houses of the legislature, have to approve expanding Medicaid before the governor can say yes or no. And unfortunately, the legislature has been very reluctant to do that, and it's been a partisan issue. And it shouldn't be. We've had Democrats are pretty much for it. Several Republicans are for it as well, mainly rural Republicans who have to deal with some of the healthcare deserts that the other speakers have mentioned too. And that's the challenge. That is the biggest challenge right now. Besides that, I haven't seen any major efforts to increase the percentage of coverage. Perhaps Pastor Norman might know of more BC's, maybe some insight into some healthcare policy I don't have, but that's the main thing I would think, and I would also said there have been some efforts to other alternative ways to increase coverage, but none have come to fruition yet.
There are federal initiatives that seek to do these types of things, but I want to speak to the first part of the question, which is the uninsured rate. How do you get to that? I think we could all benefit from healthcare navigators at various levels throughout all of our healthcare systems. So there are so many people who have some form of benefits that they just don't know how to use. And then there are people who don't know that they're eligible for benefits and they don't know how to access them. And then there's that very small population of people, and I'll use this in a particular instance that I'm familiar with, the 24 or 25-year-old young lady who may be about to deliver a child but has not completed her 10-care enrollment for the baby to be covered. She's thinking that because she's covered, that the child is covered. So navigators make a big difference. We found that in a lot of areas where there are uninsured populations, people just don't know how to navigate the complex system. And I would fair to say that most of us who are covered in this room don't know completely how to navigate our own benefits. There are areas and spaces that we have to go back and ask questions, or how much more of my deductible do I need, or is this bar count against it, and so forth. And so people who help to navigate could really help close the gap. Now, there will always be those individuals whom may not qualify because they are slightly above the poverty level or the federal thresholds of some type. But I think helping people to understand how to get insured and how to be covered, that would begin. We realize we're in a state that is just kind of turned its back towards expansion. So while we look for that as one of the silver bullet solutions, we have to also employ other means and methods to help reduce that rate.
So it's interesting when people talk about Medicare and Medicaid expansion, and I'll just offer you a bit of insight. From the medical practitioner side, we looked at this as absolute policy somewhere around 7 to 10 years ago at the TMA level, and actually polled all of our membership. And you would be very surprised that literally it was a 50-50 down the middle split of whether to expand or not. Physicians basically just, they split that vote 100%. We were incredibly surprised to find that out. Much the same as you guys probably are aware of. I would have never expected that result to come out so evenly split as it did. I would echo the same things that you're talking about in terms of the navigators, in terms of, do you know what your policy gives you the ability to do, or what is involved in your policy? I just went through open enrollment with my institution here recently, and I sat down in front of that computer and I was absolutely just dumbstruck. I just sat there like, do I need this? Do I want this? Am I gonna pay for this? How do I pay for it? What does this do to the bottom line? So on and so forth. And literally I had to have my practice administrator over my shoulder saying, click here, do this. Do you want this or do you not? And I'm like, I don't know. What does this mean? And I'll be honest with you. I mean, I went to school for 35 years. And I was embarrassed to sit there and go through this with somebody over my shoulder. She's not any less educated than me. Don't get me wrong about that, but she went to the school far less than I ever did. And it was borderline embarrassing to sit there because I didn't have the answers. So I would agree with you. I think the navigation is incredibly difficult. It shouldn't be this difficult. It's easier to buy a brand new car than it is to take out insurance. So, I hate to say it, I'm probably part of the problem, but I'm definitely not the solution.
Yeah. So as another funny part to that we just said, I was doing the same thing, getting my benefits, and right in the middle of asking the questions, a question popped up that said, would you like identity protection coverage? And I didn't know, I was like, is that identity protection of my medical information, or is that a side policy benefit that we're offering? And out of pure embarrassment, I called HR. They said, no, that's a new benefit we're offering this year. So why is that in the middle of my health questionnaire? And so that's the kind of confusing stuff that happens where I know I need help.
The really amazing part when you get to the end of all this, you make one realization when you're done. You're worth more dead than you are alive.
Well, I hope that's not the case, and I don't think your families would say such, but I think you touched on a really good point in all of this, Dr. Watson. Sometimes it comes down to money, right? Reimbursement rates. I know that we work in places that we're looking at the bottom line that determines a lot of the things we can do, the things we can't do. So looking at question number 2, when we look at Medicaid reimbursement rates, because let's say we did expand Medicaid in our state, but the rates a lot of times are lower than Medicare and commercial payers, which causes some physicians and providers to not want to participate in Medicaid, which restricts access to providers and can cause even more care delays. So what do you all feel like some of those challenges are, and what changes would need to happen if our state decided to expand Medicaid, the state of things right now, and what you all are seeing in, maybe this is not for you, but in firm practices when, and your physician groups, and just looking at the bottom line.
Well, obviously it's definitely a problem. It's hard to find, from my understanding, I've never been on Medicaid, but to find a provider who can confidently give you health care with Medicaid. I do know that TennCare has a very low reimbursement rate in comparison with other states. I was shocked recently when I toured Lavonder and also toured Regional 1 to find out that Arkansas and Mississippi reimburse at a higher rate than Tennessee, according to what they told me. And I mean, that was a little shock that we're actually a more prosperous state than both of those. We're a larger state. We should be able to do better, and that would be the only solution I could think of right now is to either they can do it administratively or legislatively we can mandate higher reimbursement rates at TennCare for these patients.
One of the things we fail at in Tennessee to understand is, number one, and I hate to label it as such, but you have to boil it down and really classify it for what it is. Medicine is a business.
Right.
It is a business exactly like Sears and Roebuck was back in the day. We're sitting in that building, and their survival was based upon profit and loss. And I think we can all agree that there's a difference between excessive profit or excessive loss, and finding a fine line between the two is where medicine needs to reside. One thing that we fail to do in medicine that has been lost by the wayside, because for lack of a better term, it's not sexy, is preventative care. A lot of these things can be handled through preventative care. The reimbursement for preventative care is very, very poor. The process is poorly done. A lot of the problems that we are currently experiencing with childhood obesity and diabetes and heart disease and hypertension and cancers and all the rest, they could be accomplished with the investment at the low level in preventative care, yet we don't want to do that. Everybody's all about the big sexy new ideas that have new machines and new imaging and new MRIs and new procedures and new robotics and all the rest. Those are the things that people like to flash up into the news and everything else, but they don't want to talk about weight loss mechanisms and control of diabetes and control of risk factors and stopping smoking and things like that. I really think that we need to take a hard look in the business of medicine of doing the small things right, doing it early, and doing it effectively to stop the big expensive stuff down the road.
I'm going to go a little bit against the grain on this, and I'm going to say I do think that there needs to be federal regulation that restricts the idea that you can't take certain patients. And I'll be real clear on that. I think that if hospitals have to treat people when they walk through the door, I do believe that in some way practitioners have to demonstrate at least the smallest percentage of their mix being individuals who may be Medicaid or Medicare patients, because if we get to cherry pick our patients, then that's going to say that there will always be marginalized people in the atmosphere, and we won't treat everybody with equity. We'll never achieve that. And so to some degree, in other parts of the world, there are restrictions on how. There's a very wonderful video called Sick Around the World, if you ever get a chance to watch it, that talks about how the patient mix is looked at in places where, you know, if you got 90% of your mix that looks one way and you're only seeing 10% of this underserved, uninsured population, you can't get these high reimbursement rates, and you can't sit there and get wealthy, and I'm not accusing anybody of that, but most certainly we have to care for those who are the least in our society. In this room, I would dare to say that most of us at one point or another in the healthcare area has worked for a Baptist, a Methodist, or a saint of some kind, especially in Memphis, you know, Baptist Hospital, Methodist Hospital, St. Francis, and then praise God for my Regional 1 colleagues who are here. They are still mission-oriented to care for those individuals who are the least among us, and so providing that level of care. So we have to get back to how do we serve, and how does healthcare help to heal? I'm going to give you a smoke and mirrors kind of thing, because I think you just saw this recently, where the effort to say we helped people and we saved hospitals took place in Mississippi. Anybody see that in the last election with Tate Reeves passing this great bill, or appealing to CMS and saying Angela Cockerham came on and said he saved healthcare, right? And so what they were saying was, we're not going to pass Medicaid expansion, and we are going to save healthcare by doing something else. Great idea. Raise the upper payment limit. We're going to get an additional $692 million drawn down because the upper payment limit will be raised. We can bill for more, and that money will be distributed among the hospitals in the Mississippi area, of which we will benefit from it because we have a healthcare system there that provides the largest amount of care across the state. However, we turned down $1.6 billion in lieu of taking $692 million because we didn't want to cover certain people. By covering those individuals, you'll have more people in the pipeline, and that way you will be able to serve more of those who are the sickest among us, and then really begin to improve the reimbursement to all of the providers, and then help to raise those rates and get better things done. So we have to be careful that we don't, fall for the smoke and mirrors game, because technically we could do the same thing in Tennessee. Hospitals will be better as a result of raising the upper payment limit. That's great, but people won't necessarily be better. Hospitals and healthcare systems will. I want that, by the way. I'm a hospitalist. I want it to be, but I do want people to be better as well.
Well, I want to save some time for questions and answers, so I'm not going to jump through all of these questions, but I want to jump to number 4. I know this is something that is important to a lot of people. So the question is, access to mental health and substance abuse care, including the opioid epidemic, are major challenges for state and local governments, payers, and providers. A, what do you see as your organization's role? What policy responses are working, what is not? And what is one or two key actions or steps that we can take action on next? So anybody who wants to jump in first, I know this is a big question.
Yeah, recently the governor was in town to help the Mental Health Alliance of the Mid-South to expand by adding a facility on Broad Avenue that will increase the number of beds that are available in the city of Memphis area, I think by 54 beds complete and for that particular service. I commend that. It's a $34 million investment. It's going to improve access for those. You have to also include, I think, in that question, how are we treating those who are in and out of the prison population? Let's be real clear. We've seen in Shelby County 55 to 60 deaths in our prison, in our local jail, just within the last year. By comparison, that's as many as you would see in Rikers, that has more than 3 times the population of our jail. And by and large, the circulatory system would suggest that they've been in and out, and there's been some drug addicted or drug related, mental health related problem that keeps them in circulation. And so by not building that network where we know who the people are, where they're going, and then making sure that they're funneled through some level of treatment and increasing the number of beds that are available and the treatment that's available, we never crack the surface of that particular problem. It's a big one. I've seen monies available, I think, from the state for mental health, which is going to be excellent. Drawing that money down would be the goal of many of our healthcare systems. And by the way, it costs us 2 to 4 times as much to keep a mental health patient in our healthcare system than it would be to put them in the appropriate level of care.
One of the issues, I think you can correct me if I'm wrong, but one of the issues that popped out in the recent special session that came up, there was actually money proposed to be set aside to increase the amount of residency and advanced training in the psychiatric and psychology community. I don't know if it actually got all the way through it or if it's being held over to January for the beginning of the next section. That's certainly a step in the right direction. Without question, we're recognizing that we have, for lack of a better term, we have a mental health crisis. And that's what we need to address, and that's what's slowly being addressed. It's not a simple solution. It takes time, effort, and energy. As a clinician, I spent many years in school getting trained and all the rest, but I'll be the first one to tell you those issues are far beyond my abilities, beyond my training. When I see the words written on the paper, I'm like, you're just befuddled by it. From the TMA standpoint, the other one to address here is the opioid crisis. That is a big issue, and especially in the eastern side of the state. We had a massive issue with, the term I would use is pill mills and that kind of thing, where people got into these situations where they were getting access to controlled substances in illicit manners. With the governor's help, we managed to crack down on most of that. We're still cracking down on it. But the opioid crisis hasn't gone away, and everybody knows while reading the newspaper every day that meth and heroin and all the rest are continuing to blossom in the community, and I don't know how to control it or how best to control it, but getting our clinicians educated, keeping them from doing the wrong things for the wrong reasons is what we're trying to achieve. Those initiatives are being worked at with the governor currently, and we're trying to move this along a little bit further.
Yeah, our special session in this past August was the impetus for this, of course, was the shooting at this private school in Nashville where 6 people were killed, including 3 9-year-old children. That brought, among other things, a lot of parents coming to the Capitol to protest, and protest works. Our First Amendment right is a good thing. It worked to pressure legislators and especially the governor to calling the special session. Now, even though guns, gun laws were a subject that that a lot of the advocates wanted to start. This legislature is very strongly controlled by the NRA and by other related groups. So any restrictions or any regulations on the firearms were pretty much ignored or defeated very quickly. What the other subject of mental health is one thing that is one of those bipartisan issues. We all agree. We might not always agree on the methods, but we agree that that's one of the major problems in gun violence as well as other problems in our society. And I think it's already been alluded to, but the one good thing probably got less attention was the additional money that was approved by the administration to go into mental health. And I can't remember the exact figure, but it's at least in the tens of millions of dollars for several different aspects of mental health. And that, I think that when the governor came to town recently, that was part of that money was to be spent here for that facility. I agree with Pastor Norman on the need for addressing mental health in prisons. I don't know the exact numbers. It's been, they said that there's more people needing mental health care in prison than there are in mental health facilities. And I believe that it's probably true, and something we do need to address. I'm hoping that in this upcoming session that we perhaps, especially if our revenue is coming in, we continue to get better than expected revenue figures in the past couple of years. And if they continue that way, maybe we can spend a little more on health care and rely on some of the experts to my right and others that on some of the best ways to spend that money.
May I make one additional comment? Accessing the dollars that are available, in one pot of money, Dwayne, there was $250 million set aside. That was the amount. And 2 years later, there was still $250 million. That was the point. I mean, that money was set aside, earmarked for mental health, but it was never accessible. And there are records of dollars in the state of Tennessee that we just got to do a better job of spending. You know, a few years ago, we had the TANF fund that was money for needy families, the Assistance for Needy Families Fund, that almost reached $1 billion, where we could, I mean, and I know families across Shelby County for sure, West Tennessee for sure, that could have benefited from those dollars, but they were sitting in state coffers. That $250 million for mental health is there. And yesterday we learned of monies from the Bush administration that were given to the state of Tennessee for religious, when they had the religious appropriation dollars that were there, that are just remaining there unused and untapped. And so I think, again, it's helping to navigate while people are getting worse and while situations are getting exponentially worse because of mental health crisis and other things that run into just daily living. Dollars are sitting there unused and gaining interest, and we brag about being a fiscally sound and responsible state, but the mental and physical health of our residents seems to be declining.
I could add too on that. I agree. And I thought it was that high figure, but it's it varies. And it's good that they're at least increasing the amount of money spending that. The TANF money, yeah, that was, I think at least 3/4 of $1 billion. It was basically being hoarded, and the good thing is public pressure came about. The more that we that was mentioned through the media, that the more pressure came down to sit. In that session that began shortly after all that came out, they did devise a plan. May not be a perfect plan, but it was a plan to spend that money down in an organized way and continue spending it after the $750 million was spent. Anyway, that's just wanted to mention public pressure is extremely important, and this group here, I'm sure, is a lot more knowledgeable about some of these particular issues, and so hopefully we can keep our eyes open and prevent some of those problems that might come about in the future.
Well, I'm gonna switch things up again, and I want to ask if there are questions from the audience that you'd like to ask our panelists while you have them here, rather than us going through our canned questions right now. So does anybody have a question? I'll bring the mic out to you. All right.
I work a lot with independent pharmacies, associations, what have you. One of the things that we are doing to keep those pharmacies in business is exploring new delivery models. You know, these are pharmacies that are in healthcare deserts, and we want to make sure that they stay in business. Can you share some of the delivery innovation models that you are doing in your organization?
I can. So one of the things that we are doing, and many of you are benefactors or familiar with the 340B program, we have recently realized that because we're in rural areas, we can expand the bandwidth of our scope of practice and service by up to 35 miles. And so in West Tennessee, I started a few years ago traveling to a lot of the places 35 miles north, south, east, and west of our hospitals. So for instance, in Tipton or Dyer County and places like that, where you may drive another 150 miles before you find a larger hospital in Dyersburg or closer to the state of Kentucky. We would go and expand the agreement by meeting with the individuals there in those spaces. I've learned that government relations will take you everywhere from dealing with the president and CMS, Director LaSure, to dealing with the constable in towns that you didn't know even had, what is a constable, okay? And so I've realized that that's what it takes. You have to really look at the fine print and the fine lines, and then by expanding the agreement, you can work with those partners in those areas who may have been falling off in their volume in the bandwagon, and include them in the process and help to keep them or keep their business a little bit more robust.
Any other questions?
Thank you. Sheena Freeman, Regional One Health. Quick question. I think we've all seen since the pandemic a lot of financial challenges that all healthcare systems have experienced. So just what are you all seeing on the horizon of the future of healthcare? And what should we anticipate from an advocacy and law perspective?
So what? All right, on the future for us, and I talked about smaller facilities where the fees are not driven by the level of access. So for instance, if you go to, with the state like Tennessee and other spaces, especially where we're rural, many people who are not covered and have access to health insurance programs rely on their medical care by way of the ER. And unfortunately, that's the most expensive and highest level you can get. Within that, there are built-in fees that are facility fees and overhead charges that you're going to get, because in order to keep a neurologist on call 24 hours a day and keep cardiologists available if a person walks in presenting in that manner, we have to pay a pretty absorbent amount of money. So what you see, what we're doing, one of the things that I'm very proud to be a part of with our system, is you see smaller facilities. In Arlington, we pioneered in West Tennessee the first freestanding emergency department. We looked at 2 additional areas. I'm not going to tell you where they are because some of y'all will go back and try to get our spots. But we're looking at 2 additional spots because we know where the volume is and where it can serve people best at a lower rate of care reimbursement. You won't find a neurologist in Arlington, but you'll have telehealth, telemedicine, where that person can read the scans, administer, for instance, if it's a stroke-related issue, the drug, the TPR, TPO drug. What is TPR? TPA. ARL, I get my alphabet mixed up in hospitals sometimes. All right, so the TPA drug, which I'm very familiar with, but here it is. You can deliver this care, and it's going to have to be that way. We just opened another facility in Jackson, the Jackson Clinic, which is an outpost at our Carroll County Hospital. So we have services where people can go in, and the beauty of this facility is you can walk in today and you can say, okay, I'm seen by my doctor. My doctor says I need to do surgery within 2 weeks or a week or so. And typically that would mean the doctor would tell you to go see your cardiologist to get a clearance, go see this person to get a clearance, go see that person. You catch the elevator in this building and you go downstairs and you get it all done the same day. You get the blood work, you get all of these things done. So your time and the cost of care is now still at the same expert level, but it's being delivered in all one space, and reduction of time and cost is brought into play. I think that's one of the ways we're gonna have to see. I think we are in an era of no longer seeing the huge hospitals except for the academic medical centers that may come about.
Okay, I'm going to just add a couple of things under what Pastor Norman said. Yeah, definitely telehealth is going to increase in the amount, especially in rural areas, but actually in urban areas as well. My wife and I have had to deal with, have our own telehealth visits, so forth, and in addition to that, I think Tennessee has been more active in establishing compacts with other states in different areas of different medical professions, which since we border 8 other states, we're one of 2 states that border as many as we do, and many of us are close to other states, so having interstate compacts has become even more important. And just my observation, I know that one thing we've had to address is full practice authority for nurse practitioners, and the legislature has not it's not been successful so far. But regardless of whether it is or whether it isn't, I do see more nurse practitioners perhaps being in certain areas where physicians are either non-existent or very underserved too. So that's one other possibility.
Yeah, so I was kind of stole my question a little bit. Obviously, so I work with a physician practice group, and we work with all the hospitals. And for all of us, we kind of saw the financials for all of the big hospitals You know, we hear from the Medicare standpoint, there's a 3% increase, I think, coming in the fee schedule. The physician practice group is set to take cuts. I think we're sitting at 1.5%. So we talk about primary care, you know, kind of the access to care and all that from the physician environment, like we're sort of taking, you know, more from the physicians, but it also, that 3% doesn't seem like it's gonna close the gap for the hospital systems either. So, I mean, I guess from a local standpoint, we're kind of in trouble all around is what it feels like. So I guess I just wanted to know from the national standpoint, I mean, what do you see coming down the pike? I mean, labor costs continue to go up, drugs are continuing to go up. I mean, last time we spoke to our MGMA group, I think I asked you for your crystal ball, so I guess I'm doing that again. You know, at what point do we start to look at single payer? I mean, when does, I don't hear a lot of talk about that the last couple of years, so just, I don't know, where are we going?
Crystal ball, bro.
Yeah, I'm here for it, I'm here for it.
I'll correct some of your numbers real quick. You're actually looking at a 3.4% cut across the board. It's not gonna go away, folks. So whatever you're doing, you need to tighten up the belt and do it again. So let me ask this question real quick, for those in the room. How much do you think that those cuts have either gone up or down over the last 10 years? Just throw me a number.
Can you repeat the question?
How much?
Can you repeat the question? Sorry.
How much do you think the cuts or the benefits have gone up or down over the last 10 years in terms of reimbursements to the physicians and physician practices and medicine in general?
I'd say 15 to 20% reduction.
15 to 20% reduction, okay. Any other numbers out there?
5%.
Okay. Would you be surprised to learn that it's 26% over 25 years? Name me a single other entity or a single other employment that has existed that has lost over quarter of their reimbursement over 25 years.
Pastoral ministry.
Stand corrected. There's more. And they're equally as important. Absolutely, I can vouch for that. But here's the bottom line. The government looks at this every year, and every year they go, okay, you're not going to get a cut. They consider that a bonus. That's not a bonus to us that are paying overheads and employment and insurance and everything in between. I mean, he and I could go on, that our expenses don't go down every year. The cost of doing business in medicine does nothing but goes up. Buying the latest widget, buying the latest tool, buying the latest shovel, it goes up. It doesn't go down in price. So everybody likes to talk about, you know, the cuts or the benefits that physicians are getting. Well, they're not getting benefits. That's the bottom line. We've been cut and cut and cut. And when we sat through the pandemic and we worked through the pandemic and those people came in every day, we didn't get a bonus out of that. We didn't get a benefit out of it. We got cut and we're about to get cut again. So
I'm sorry.
go ahead.
No, so the one thing that I don't see as a benefit to the current situation is what I think we're trying to do to fix it for the future. And that is the reduction of debt by which students are graduating with in the graduate medical education area and going into the practice of medicine. Many times, physicians have started out with debt and high debt. There are more spaces, quote, being sought to be put into the market space where rural practice of medicine will absorb the debt and allow the individuals to practice and get off to a level start versus starting behind the line. That's one thing that I see. But I don't think we're in a place, if I'm being that we ever catch up. Because as I have shared with people, really seriously in my own discipline, if you go 2 to 3, 5 years without increasing, while the expenses and the cost of doing business are currently increasing, you never catch up. The profit never catches up. You can come and try to jump me up by 10%, and what you've really done is gotten me to 2 years ago what I should have been at. And then we try to go from there, and the costs continue to go up. So even with what we might see with the raising of upper payment limits and things of that effect, you're going to get it out there. You're going to say, we're gonna raise upper payment limit, then the expense is gonna start going up. It's gonna close the gap. And so you really don't fix systems like that. You break even and cut your losses at some point, or you have to start completely new, because when you, and I'll use something that's akin to people, and I hope it's not overly sensitive. It's almost like trying to fix reparations in America. It's just impossible to do, because what is the value of it today versus where it would have been if it had been done in the very beginning at the time that it should have been done.
So have we considered with community paramedicine working with the EMS Bureau? My understanding is the legislature has not been very receptive to that because of other associations. But community paramedicine, being able to go into the home and making sure that patient is taken care of, taking their medicine, what is their blood pressure today? It's great for readmissions. It's great for making sure those patients that are CHF patients are doing what they need to do. And back to your point, can take those medicines out for them. Where do you see the legislature going with that? Because we're, as a licensed EMT and a healthcare executive, we are always looking at that, because I run ambulance companies, and I think they're already there. They've got the people to do it, but can we expand that to almost a nurse practitioner with a paramedic?
Well, a lot of that, I understand your question, but that entity in terms of EMS, if you're talking about them specifically, EMS is stretched thin already.
Yeah.
I mean, I would not throw this problem on top of EMS in any form or capacity. We've alluded to it earlier, and we've talked about whether or not to provide full practice authority to nurse practitioners and that kind of thing. Let me just give you some numbers. Most nurse practitioners have about 700 or 800 hours of training. Most physicians, by the time they're out of residency, completed all the training that they're doing, number one, you're about 30-something years old. Number two, you have probably on the order of 10 to 12,000 hours of training. It's completely inadequate to have a nurse practitioner have full practice authority on their own. TMA has espoused what we call a physician-led team-based approach to the care of patients, which means that ultimately there's a physician at the head of that that's guiding that therapy to make sure it's being done right for the health of the patient in a low-risk manner as possible, to make sure that nothing's missed. That's what we're trying to achieve. We've espoused that idea for 10 plus years through the legislature, and it's not, everybody understands it, but they haven't gone over the paperwork yet, for lack of a better term. We're hoping this year is the year that we get that physician-led team-based approach put into place, have an agreement both with the physician's assistants and the NPs, and then we move forward and we provide the best care we can for people. So.
Legislature.
I haven't seen a lot of major legislation come about, and I don't anticipate it coming about what you're talking about. I've been shocked several times to find out some of our rural salaries they make, and
Yeah.
wonder from time to time, why are you even doing this? But I'm glad you do. Generally, what comes about will be a temporary fix in a certain county or a certain area to do that, and it always passes when it comes about. But I don't see any widespread change at this point. I mean, I would be in favor of it. I don't see it so far.
No, and go ahead, Doctor.
I was going to say record sharing is another major part of the problem, because if you recall, several years ago, IBM introduced an initiative where we worked on this in the city of Memphis, where they were going to equip smaller cars to go to homes to determine whether or not a person really needed to go to the hospital. As a result, and unfortunately this did happen, it's on record, they went to the home of a lady who looked perfectly healthy. She said she was having an episode, wanted to go to the hospital. They determined she didn't need to go. She called again the very next day. They went to the home. You're fine, check everything, you don't need to go. She died that night. The lack of record and integration of us knowing, or the EMS knowing what this lady was experiencing through her health care, her medical health record, was just not connected. And so without that, that's going to be a major problem in delivering the care. It's doable. We explored during COVID, if you recall, the healthcare at home initiatives, and it was working. But to get behind it and to really make it something that needs to happen, it's going to take a lot more energy.
Sure. Just to give the audience some perspective, an EMT in Memphis is paid more than anybody else across the country. An advanced EMT right now is making $20 to $25 an hour. You go to Nashville, that paramedic is making that, and they're a higher level of care. So Memphis is having to eat a lot of payroll because there's a lot of companies out there doing the service, but they don't provide the service in a timely and efficient manner. But they're paying their people a lot more than what we paid 2 to 3 years ago. We were paying EMT $16 an hour.
Yeah.
And paramedics right at $20 to $22 an hour. And now, an basic EMT or an advanced EMT is making $8 or $20 to $25 an hour. And you're not getting any reimbursement for that.
One of the issues that's come up is the education of paramedics and EMTs. I think there's a current proposal. The state of Tennessee disallows an EMT or a paramedic who's been trained elsewhere to come in and make application to become an EMT in the state. And we're trying to correct that initiative. That was brought up recently. I don't know the status of it, but it has been looked at recently.
There's a big push for a compact type license.
Correct. They're trying to, I believe it's mostly coming out of Mississippi is where the problem lies.
Correct. And they're only doing it for emergencies. When the governor declares an emergency, it needs to be just like nursing.
So as in everything, once we can provide more, the cost of doing so will go down. So
Absolutely.
I'm hoping that we can address that.
Thank you.
Any other questions?
I have one more about, we're talking about different providers, nurse practitioners. I'm a nurse myself. You have a valid point. What about, I work with a lot of, again, pharmacies in the state of Arkansas, and we have launched several projects there on treat and release. State of Arkansas has passed a law considering PharmDs providers for certain sets of CPT codes. Can you speak to the state of Tennessee if we're going to do that here?
If we're going to do it here,
Yep. Or if there's any plans to do it, or if there's any consideration to
I don't.
redesignate PharmDs into providers?
At this point in time, I mean, if we can't come into agreement to actually get medically trained individuals, i.e. nurse practitioners, PAs, and MDs, talking on the same table, I don't know that we're gonna get enough with PharmDs trying to treat anything.
So since there's an evaluation after this, what answer do you want to hear? There's really no way, I mean, no one.
I don't know, I was just wondering if that was being under consideration
I'll say this.
in Tennessee.
Some of the things, I think the nature of your question, and this is about healthcare in general, some of the things that are extremely logical and make a lot of sense to us and to the people in this room, they become politicized, and it's just no way of getting through it. I mean, everybody, and I'm gonna go out of Tennessee to make it a comfortable conversation. Everybody in the world knows that healthcare in Mississippi is suffering. And to turn down $1.6 billion that could improve the lives of some of the sickest people in the nation in favor of saying it's a political thing and I'm not gonna do it. And when 72% of the residents there say they're for it, and about 60% of the legislative group says, we would pass a bill, but it's going to be vetoed. It just doesn't make sense. And so I think what you're asking is a question that says, does this make sense to do? Of course it does. Will we do it, Dwayne? Dwayne and I have known each other a long time. I can do it.
Well, I want to just thank you all for coming out today, and of course, thank our panelists for just giving me their time. You all threw some difficult questions, and they were able to answer them on the spot. This is always one of our hottest topics, just talking about what's happening in policy and in the government. So I appreciate your time. Are there any other announcements from? No. Remember the meetings in December? December meeting, and you'll get an email.